In the MARIPOSA trial, the overall survival analysis was presented at ELCC, showing that the combination of amivantamab and lazertinib was able to significantly improve overall survival, with a median survival of approximately 3 years for osimertinib and not reached for amivantamab-lazertinib combination. And the hazard ratio was 0.75. So this is the first study demonstrated that it was possible to improve overall survival for patients with EGFR mutation and advanced non-small cell lung cancer since the FLORA trial. So this is a great advance, of course, for the management of this patient. However, this was at the cost of a significant amount of additional toxicity, especially the dermatological toxicity, the infusion-related reaction, and the risk of venous thromboembolism at the beginning of the treatment. So all these toxicities need a proactive management in order to reduce the rate of high-grade toxicity. And clearly, the skin and the scalp toxicity is an issue and still difficult to manage for the patient and also for the oncologist. Well, we have now two possible intensified first-line treatment options with the amivantamab-lazertinib combination in the MARIPOSA study and the combination of chemotherapy and osimertinib with the FLORA2 regimen. Both probably will lead to an improvement of overall survival. This is demonstrated for the MARIPOSA regimen, and the overall survival analysis of FLORA2 will probably demonstrate the same magnitude of benefit. And this combination works not by improving the response rate, which is very similar to that of osimertinib monotherapy, but it works by extending the duration of response by preventing or delaying the emergence of acquired resistance. And the magnitude of the PFS benefit translates into an overall survival benefit because this is a big advance in terms of PFS. The magnitude of benefit in terms of PFS is important enough to translate into an overall survival. So probably it is better to give the best treatment option in frontline. However, all the patients are not eligible for such combinations, for the frail patient, elderly patient, and for patients who probably wish to preserve their quality of life, which is probably easier to do with osimertinib monotherapy rather than with a treatment combination. Osimertinib monotherapy remains still a validated option. Well, we are inclined to reserve the treatment combination for the patient with a high risk of early disease progression on osimertinib monotherapy. And those patients with high risk of early disease progression are patients with a high tumor burden, with CNS metastasis, with some genomic profile, detectable ctDNA at baseline, probably the TP53 mutation, probably also the exon 21 mutation rather than exon 19 deletion. And also, we have also to consider the patient comorbidities and his ability to tolerate chemotherapy or amivantamab-lazertinib combination. So all these factors have to be taken into account before selecting the best treatment option. And for the patient with a high-risk clinical or genomic profile, I would be attempted to give a treatment combination which is more effective. As I have not seen all the communications because we are still at the beginning of the conference, I will probably selecting the communications about EGFR mutations, because this is in this field that we will have probably the most important advances. We have also some interesting communication for the KRAS mutated patients with some combination with cetuximab and KRAS inhibitors. So we have also some interesting data in this field. But I think for ELCC 2025, probably EGFR mutated patients are probably the most important setting in terms of advances. I think this is the MARIPOSA trial, which is clearly a practice-changing study because there is a significant and clinically relevant improvement in overall survival. So clearly this is the study which is probably the most practice-changing study in this conference.